This is the second tutorial on volume control ventilation. Specifically, it's about synchronized intermittent mandatory ventilation. I'm also going to introduce pressure support in this particular tutorial. This is part 2 of volume control ventilation, and in this tutorial I'm going to talk about synchronized intermittent mandatory ventilation. Previously, we looked at the principles of volume control ventilation, and we visited volume assist control. Following an example of how volume assist control works, I discussed the advantages and the disadvantages of that particular mode. This time I will discuss initially intermittent mandatory ventilation and the history of how we got there, and then the more modern, if you want to call it that, mode, synchronized intermittent mandatory ventilation. Let's start with IMV. If you travel back to the beginning of the critical care era, you will hear stories about how mechanical ventilation was essentially invented in Copenhagen during the polio epidemic of the 1950s. But realistically, the major driver of modern critical care was the need for a location to gradually liberate patients who had undergone major surgery, such as cardiac surgery, from mechanical ventilation that was commenced in the operating room. As such, many early ventilators in the ICU were essentially the same machines that were used in the operating theatre. Consequently, intermittent mandatory ventilation and its progeny is instantly familiar to any anesthesiologist who's used a ventilator in the last 60 years in the operating room, even though, in my experience, the majority of them don't really understand the modes. This is your opportunity. Well, let's start in the 1950s and 60s when mechanical ventilators were not sophisticated. These were mechanical machines. There was no real electronics in them. And the early machines, as I've mentioned, were used in both the operating rooms and the ICU. What you notice that's different about this machine versus what I showed you earlier on is that there is a bag on the expiratory limb. As flow is going around the system continuously, that bag acts as a reservoir for inspired gas, just like a non-rebreather face mask is. The bag fills up during that window between inspiration and expiration. The gas is flowing all the time. You see here that there is, when we actually cycle this ventilator, it's time cycled, the patient gets a breath, and the breath expands the lungs and pushes the diaphragm down. There is essentially no difference between this controlled IMV breath on the ventilator and what we saw with the controlled breath on assist control. The ventilator time triggers and the volume cycles every 5 seconds. So you can see here, I have up here an IMV tidal volume of 450, a rate of 12. There's no inspiratory pause, although that could be applied without too much trouble. Now, the ventilator screen, and of course, there would not have been a screen or a waveform display back when this was the way people were ventilated. But on this particular machine that I've jerry-rigged, you can see there is a square-shaped constant flow waveform and the characteristic shark's fin pressure waveform of a volume cycled breath. So this is volume control, volume cycled breath, and really no different from any other volume control, volume cycled breath. Exhalation, as usual, is by elastic recoil, and as always, we're going to measure the exhaled tidal volume. Now let's move on to what happens in the window between the mandatory breaths. So we don't have any breaths being delivered at this point of time. And when the patient breathes, there's limited flow. There is flow going around the system, but the flow must be drawn principally from the expiratory limb of the circuit, not from the, even if there's a few liters being dialed up of flow going in the inspiratory limb, that's just not enough to meet peak flow demands on this very rudimentary ventilator. So the patient will draw breath from the bag on the expiratory limb. So the patient takes a breath and they draw their breath from that bag. And as you can see, when you look at the waveform here, it's a sinusoidal flow pattern and it's a sinusoidal pressure pattern on the display, and the bag empties during inspiration. And then when the breath is completed, because the flow is continuous through the circuit, the bag will refill. So this is what happens in IMV when there is a spontaneous breath. Traditionally, when IMV was used in the ICU early after the patient was brought back from the operating room, or perhaps when they were intubated for some other reason, they were put on controlled ventilation until they started breathing up and drawing gas from the bag. And then they were usually put on a T-piece. This is essentially a piece of tubing with high flow running down one end and a PEEP valve on the other end, where PEEP will be drawn at 5 centimeters of water or more. Essentially, it was a resistance to exhalation, so it pushed pressure back up the tubing. That's what a T-piece is prior to extubation. This implied that the spontaneous breaths induced fairly high workload because the patient was breathing through a narrow piece of tubing, the endotracheal tube, and they were only drawing a modest flow of gas from the bag. This is very different from that high flow that you'll get on a modern ventilator. So this is what IMV looks like if you were able to give it. You can see here what it looks like. Our patient is getting 2 different breaths. They're control breaths. There's no assistance here because there's no assistance in IMV. And when the patient takes a breath themselves, it's a characteristic sinusoidal flow pattern. So that's IMV. Huge drawbacks to this mode of ventilation. The first problem is breath stacking. And breath stacking means that the patient might be trying to take a breath themselves at exactly the time the ventilator decides it's going to discharge into their lungs. So they make it a massive tidal volume. The second thing is that there may be air hunger. The patient may be really sucking hard on that endotracheal tube, on that tubing to get flow out of the bag. And that's not great. So it's okay for the patient who has relatively normal lungs and a large endotracheal tube. But if there's widespread atelectasis, the work and resistance of breathing is high. In order to resolve all of these problems, in the late 1970s and early 1980s, with the advent of computers and electronics and servo circuits, it was possible to evolve this mode of ventilation into something that became known as synchronized intermittent mandatory ventilation. So let's just summarize what happened back then. First of all, the patient could take a breath within that particular time frame, and that breath would be assisted, just like an assist control breath. So within a window of time of the breath that was mandatory, if the patient took a breath, they synchronized together. The second thing is outside of that window, the patient could breathe spontaneously, but they would get 2 things that would help them along. And that would be, first of all, that they would get more flow than would be traditionally delivered by the bag because it's coming from the ventilator. So the flow would be much better. And they could now get a new mode that was developed specifically to assist the spontaneous breath in SIMV, and that is known as pressure support. Now, pressure support is used as a standalone mode of ventilation now, but back then it was invented purely to help the spontaneous breath in SIMV. And this is what SIMV looks like without pressure support. This is a decades-old printout for a patient on SIMV volume control with unsupported spontaneous breaths. Note that the patient is getting 2 types of breath. The first one is a volume-assisted breath. I can say it's a volume-assisted because of that little divot before the pressure waveform. The second is a spontaneous breath here. and that is characterized by the sinusoidal patterns that you're familiar with. So you can see here the flow pattern for the controlled breath and the assisted breath is a decelerating flow pattern, but this is volume control, hence the shark's fin shape of the volume of the pressure waveform. The second breath is unsupported. Now, if you look at the flow rate here, the flow rate here is about 60 liters for the patient who's getting the volume breath, and it's about 25 liters, still fairly generous for the spontaneous breath. But if you look at the volume measurements, this patient is getting very, very different volumes. The patient is getting the controlled or assisted breath is getting a pretty impressive 700 ml tidal volume. The spontaneous breath is struggling to reach 250. And that suggests that the patient is working fairly hard when breathing spontaneously without additional support. And hence, this is the reason why pressure support was created to help that spontaneous breath, just to push it up into a window where the patient doesn't have to work. This is how you set up SIMV on the ventilator. The settings are SIMV, volume control, the flow trigger, and constant flow waveform. This all looks very, very like assist control, except for the setting of pressure support. Here's the pressure support setting. It's 7 in this particular case. And of course, with pressure support, you also have the expiratory sensitivity for flow cycling. So this is what SIMV looks like. And here are the waveforms that we would associate with SIMV and pressure support. And they have 3 different types of breath here. A volume assisted breath here. You know it's an assisted breath by the little divot before the pressure waveform. A controlled breath. And then a pressure supported decelerating flow pattern breath that flow cycles at a proportion of peak flow. Note that the 2 volume breaths deliver identical tidal volumes, but the pressure support breath delivers a significantly lower tidal volume. But of course, it could be a higher tidal volume depending on how much pressure support you apply. You could always adjust the pressure support so that you get more or less the same tidal volume as you see with the controlled breath, but will always oscillate. It will never be the same from breath to breath because of the difference in the pressure ramp, as I'll discuss in the next tutorial where we talk about pressure support ventilation. Well, there's more to SIMV than meets the eye. Every manufacturer has a different algorithm for what the SIMV period is. This is the window in which the patient can take a breath or will get a mandatory breath, but they're effectively the same. And it might be 5 seconds on one machine, or a proportion of the I to E ratio on another machine, or a proportion of the minute. It really does vary, but essentially within this window, the ventilator waits and waits and waits to see if the patient takes a breath. And if they don't take a breath, then the machine delivers a breath. And outside that window, the SIMV window, if the patient takes a breath, it will either be unsupported or will be pressure supported. The nice thing about SIMV is that it's not an all or nothing mode of ventilation. It can be used for partial ventilatory support in someone who is emerging from anesthesia or who may be kind of hyperventilating and you don't want them taking a minute ventilation of 15 liters per minute. And the breaths can be gradually weaned and the patient changed over to pressure support, although it's never been shown to be a good mode for weaning people off the ventilator. I think we should just move on a bit now and just give you a little more detail about how the SIMV period works. And this is time in seconds along this blue band here. And what we have here is the SIMV period, then a spontaneous period, an SIMV period, and then a spontaneous period. So these are 2 different windows in every minute, and it cyclically goes from one to the next, from one to the next, one to the next. So let's go to our first SIMV period. So this is the first SIMV period. And during this time, the ventilator is waiting for the patient to take a breath. And it could be 3, 4, 5, 6 seconds. It varies. If no breath is detected by the ventilator by the end of the SIMV period, then the ventilator will deliver a mandatory breath. Immediately after that breath has been delivered, the spontaneous period starts. And during this time, the patient can breathe spontaneously and the breath may be unsupported or pressure supported. Now we go back to the SIMV period. Now you'll see here that the patient takes a breath at this time, and it's an assist control breath identical to the mandatory breath. Now what's interesting about this SIMV period is that if you look at it carefully, you'll see that it's kind of shorter than the previous SIMV period, and there's a good reason for this. As soon as that breath is delivered, we go to the spontaneous period. So the SIMV period is not always the same length. It varies depending on whether the patient takes a breath or doesn't take a breath. If the patient isn't breathing at all at any stage, it's always essentially the same. It looks like assist control because they're not taking a spontaneous breath either. But where there is patient breathing and they're assisting and they're taking spontaneous breaths, the SIMV period dynamically changes from breath to breath. So immediately after that breath is delivered, now we're into the spontaneous breath. And now the patient can breathe away themselves. So it varies a lot, and it looks quite ugly if you actually look at the ventilator screen. An example of one of the algorithms that's used by a company is the breath cycle time on the Servo-i ventilator that's made by McQuay. And if you set up the Servo-i ventilator with an I/E ratio, there is an adjustment in it called the breath cycle time. This is an I/E ratio, not an inspiratory time. So you could set up, for example, an SIMV rate of 6 breaths per minute and an I/E ratio of 1:2. And then you set a breath cycle time of 3 seconds. This means that the inspiration will take 1 second, the expiration will take 2 seconds. So that's the full breath cycle time. You could adjust that and give them a longer inspiration or longer expiration, but the I/E ratio is 1:2. So it's a way of kind of setting in an inspiratory time and an I/E ratio at the same time. Okay, so now we have 3 seconds for our breath. As the total time for each breath is 10 seconds, so we've given 6 breaths, 10 seconds for each breath, and the SIMV window is 3 seconds, then the spontaneous breathing period is 7 seconds. So the way it's set up is like this: SIMV period, 3 seconds, spontaneous period, 7 seconds, SIMV period, 3 seconds. And in that SIMV period, you may get a mandatory or an assisted breath. And then, of course, in the spontaneous period, it's unsupported or pressure supported, and then we're back to our mandatory or assisted breath. But keep in mind that if the patient does take a breath early in the SIMV period, they go right on to the spontaneous period. Here we have our late 20th century mechanical ventilator, and the ventilator settings are SIMV volume control. We've set the rate, the tidal volume, the peak flow, the FiO2, the PEEP, and the pressure support levels. Now let's roll the animation. In this situation, the SIMV period, which is in seconds, runs along. And if at the end of this period the patient has not taken a breath, the ventilator will time trigger a mandatory breath, in this case a constant flow volume cycle breath. You can see that a little C has appeared on the ventilator screen to indicate a controlled breath. Immediately after the breath has been delivered, the spontaneous period starts. Let me just roll that animation for you again, just to watch what happens here. There we are, triggering flow going into the patient, airway pressure being measured, and that is happening at the end of the SIMV period. Let's roll on to the spontaneous period. So once that breath is delivered, we're in the spontaneous period, and we're waiting for the patient to take a breath, but nothing happens. So the spontaneous period just rolls and nothing happens during that period. And then we get back into the SIMV period and the patient is going to take a breath. So you can see here, the patient drags a bit of flow just at the beginning of the SIMV period. They trigger the ventilator and this causes the lungs to inflate. The ventilator, so this is an assisted breath. The ventilator immediately goes back into the spontaneous period and the SIMV period ends. And this looks exactly like the controlled breath, except for that little negative pressure divot on the pressure waveform that I always remind you to look for. An indication that this breath is an assisted breath appears on the screen. In this case, you can see the A. And by looking at these waveforms, you would find it very hard to distinguish between assist-controlled ventilation and SIMV and volume control. Let's just roll that one again. So you can see here, the flow by patient triggers just at the beginning of the SIMV period, and this causes the ventilator to generate a flow of gas up to a tidal volume of 450 mils, and that is an assisted breath. If this screen was shown to you out of the blue, you would likely think it's volume assist control with no inspiratory hold. This is a straightforward volume cycled constant flow picture with identical tidal volumes, but in fact this is SIMV, just that the patient isn't actually taking any breaths, and this is a patient, for example, who might be paralyzed. Exhalation is, as usual, by elastic recoil, and the tidal volume is measured at the end of exhalation. And of course, the tidal volumes between the controlled breath and the assisted breath in SIMV are exactly the same. It's because they're all volume breaths, and that tidal volume here was set at 450 mils. Well, let's move along. Now the patient rolls into the spontaneous period, and then during that period, the patient deflects the flow and triggers a breath. Let's roll the animation here. As this breath is outside the SIMV period, the breath will not produce a volume assist breath, but a pressure supported breath. Note the S on the screen indicating that the breath is spontaneous, and the screen waveforms, the pressure waveform preceded by a divot, and it's flat topped. It's a flat topped waveform, typical of pressure controlled breaths, and the flow waveform is a decelerating flow pattern that's shaved off because it's flow cycled, indicating pressure support. So this is pressure support ventilation, a pressure supported breath that's happening during the spontaneous period. When the patient exhales, the measured tidal volume in this situation is going to be different because it's a different type of breath. And in this case, the measured tidal volume was 250 mils. So in SIMV with pressure support, the tidal volumes are different. You get the same tidal volume for the controlled and assisted breath and a different tidal volume for the pressure supported or spontaneous breath. You may not give the patient pressure support, but most ventilators now will give a little bit of pressure support, even if you set the pressure support at 0. And so here we have our patient. You can see here, I've just shown you the control breath there. You can also see that this breath here is a pressure supported breath. The colors are different on this particular ventilator. And the last breath here is an assisted breath. And the reason I know this is an assisted breath is not that I can see much of a divot before the waveform, but because there's a dirty big A here in the left corner of the screen telling me that it's an assisted breath. And you can see that the time lag between the control breath and the pressure supported breath is very different. Before the first control breath, there was 2 pressure supported breaths in a row. Then the control breath happens, and a bit of a lag, and a bit of a pressure supported breath, and then an assisted breath very early in the SIMV cycle. Well, when might one use SIMV and pressure support? Well, it seemed to me that it's a decent enough mode of ventilation to use where muscle relaxants are gradually wearing off and the patient is beginning to breathe. And to me, the obvious place to use this is in the operating room, where you may have given muscle relaxants to a patient to intubate them, but have no interest in giving muscle relaxants subsequently during the case, and you'll allow the patient to start breathing, and perhaps you might help them with some pressure support when they start breathing themselves. You know, there is an argument for also using it post-operatively in the ICU. The other time that I can see that SIMV might be a useful mode of ventilation is where you're worried about the patient hyperventilating. For example, patients have a lot of pain, or if they're agitated, if they have liver disease, or they have a brain injury, and they may be harmed by a respiratory alkalosis. Now, neither of these are particularly compelling reasons, and there are plenty of ICUs all over the world who've never ever used SIMV, because in either situation, an attentive bedside practitioner would observe the spontaneous breathing efforts and then pretty much switch the patient over to pressure support or leave them on volume assist control. And there really is no great evidence of benefit for using SIMV with pressure support for ventilator liberation, or frankly, for any mode of ventilation for helping you with ventilator liberation. And there is this whole question of it being a mixed mode of ventilation where you're mixing volume and you're mixing pressure. So I don't know, it has a role maybe, but only in very limited settings. It does remain popular in some neuro ICUs and some other ICUs where anesthesiologists are the main practitioners in the unit. And I wouldn't criticize doctors for using this mode. I do think it's a suboptimal approach to be using in somebody, for example, who has hypoxic respiratory failure. Now, it is worth keeping in mind that SIMV can be volume controlled, it can be pressure controlled, or it can be pressure regulated volume controlled. That's volume guaranteed pressure control. I find these unnecessarily confusing. I'm not sure why you would want to use SIMV pressure control when there is a vastly superior version of the same mode out there known as bilevel pressure control, which I'll talk about in 2 lectures' time. For volume guaranteed pressure control, to use it as SIMV seems to me to be a little bit inelegant, because you already have done much of the work and see much of the benefit from using pressure control in the patient. And so before adding all the pressure support. And so I don't really get it. If you're going to use pressure control, you're better off using a modern pressure control mode or pressure assist control rather than using an IMV version of it. This is one of those kind of versions that you will see on your ventilator. This is volume guaranteed pressure control in SIMV. And I've said to colleagues who I work with, if they want to use PRVC, SIMV, or this particular mode, if they can actually explain to me what is happening from breath to breath, then they can use it. But as really nobody's quite sure what's going on with the patient from breath to breath in this mode, I think you're much better off just using the assist control version of it. So let's review this particular tutorial. In this tutorial, we did the second part of volume control modes of ventilation and continued our discussion about volume control itself. We looked at, let's review this tutorial. This was the second of 2 tutorials on volume control ventilation. We discussed initially how intermittent mandatory ventilation was developed essentially from ventilators that were used in the operating rooms. There were multiple problems with IMV, particularly breath stacking and the lack of the support for the spontaneous breath. Consequently, IMV evolved into a novel mode in the 1980s known as synchronized intermittent mandatory ventilation, where if the patient took a breath within the window of the controlled breath, that was synchronized, that was usually a volume controlled or volume assisted breath, very, very similar to what you see in volume assist control. Outside that window, the breath was spontaneous and was usually supported by a novel mode known as pressure support. In the next tutorial, we're going to start a 4 tutorial series on pressure support ventilation itself. I think this is a really important mode to understand. We'll start with a discussion about assisted spontaneous breathing and why you should assist the spontaneous breath. Then we're going to go back to looking at triggering in more detail than we looked at in the early tutorial. And we're going to look at problems with triggering, specifically under triggering and over triggering. I'll see you then, and I guarantee you'll learn something. Well, I hope you found that useful. Please leave some comments below, subscribe to the channel. There will be some subscriber-only content on this channel, and feel free to contact me or follow up on ccmtutorials.org. The next series of tutorials will be on pressure support and why I think it's really important that you understand this particular mode of ventilation before we start looking at hypoxic respiratory failure.